Thank you so much, Chairman Miata, for the opportunity to be here today, and Asahi. Thank you, Dr. Walker, for putting together this lovely conference every year. And I would like to talk a little bit about crossing previously uncrossable lesions. And this cross-lead line of wires from Asahi really is what's making that possible, and it has totally changed the game in terms of what's possible now. Oh, great. Okay, got it. Very good. So I just thought I'd jump into a case to kind of illustrate what is possible with this new line of wires. So we have a 91-year-old female, Rutherford 6 CLI, prior failed bypass graft, extreme calcification on ultrasound, hostile femoral vessels. There's flow in the common femoral artery and in the proximal SFA, but kind of beyond that, things get lousy. Here's the occluded bypass graft that was not an acute occlusion, but happened sometime in the last year. And then dampened flow occlusion with extreme calcification of the mid-distal SFA, and then some reconstituted flow distally, but very dampened. And then it's more of the same with the tibials, so the anterior tibial artery is completely occluded. The posterior tibial and the common plantar, all of the plantar vasculature is completely occluded and obliterated with calcium. And then the only flow we have to the foot is this faintly reconstituted dorsalis pedis with really minimal flow in it. And this is what's keeping her foot alive. So no surprise that this patient is having severe difficulty. And then more calcification. I try and follow the pedal vessels all the way up to kind of do procedural planning. And in this case, the ostial AT is completely obliterated with calcification. So this is going to be a really hard case, especially when that ostial AT is occluded and you have to re-enter the popliteal directly. That's about as challenging in anatomy as you typically come across. So how to do this case? You need a lot of push to get this done. You need to have inline push. So you could go antegrade or you could go pedal, but up and over is probably not going to work too well. And then for the antegrade approach in a 91-year-old small female with significant calcification, there's substantial bleeding risk. So in my practice, I like to go typically to a primary occluded vessel access approach when possible. And that's kind of what I did in this case. So occluded vessel access of the distal anterior tibial artery just above the ankle. In the old days, I used to use the Mongo 014 and 018 ES to do this sort of occluded vessel access, but with the new crosslead line, I've kind of transitioned to using the 014 or 018 crosslead Pro. This is a very, very durable wire. The nitinol, the tip is a nitinol core with the Act 1 technology, polymer jacket, and hydrophilic coating, and then the shaft of the wire is stainless steel and extremely supportive. So this thing, you can kind of curl into a ball or a spindle, go subintimal, and then take it out, reshape it, and use it to complete the case. So if there is any wire that you can get a kind of one case, a one-wire case done, even in a complex patient like this is it. And really does not deform or become unusable even when you ball it up. It's also got an extremely supportive distal shaft, which has been a game changer in my practice. So I like to go retrograde a lot, and in small vessel tibials, I don't like to put sheaths in. So I will often use an 014 crosslead Pro, access the tibial, wire across an occlusion, and then just bear back an 014 balloon. And prior to this wire line, there was no 014 wire that was supportive enough to actually get a balloon without a sheath into the vessel, and now that's possible. So it makes it possible to do retrograde access in 1 millimeter vessels and still get a good result and not occlude the access point. So getting back to this patient, this was an 018 crosslead Pro looped into the hibernating lumen of the anterior tibial artery, kind of progressed forward as far as the loop will stay tight. But somewhere along the course of this vessel, we hit severe resistance. And this is the problem with these occluded and extremely calcified vessels, that the path of least resistance is often out of the vessel rather than through, because the calcification is so extreme that the wire will go anywhere but through. So if you want to cross luminally and get there, you need to kind of find some way through the calcium and find a way to follow the path of most resistance rather than the path of least resistance. So in this case, I got to the ostial AT, got some blood back, see some branches, so we're in sort of the right place, but then we have more calcification on top of it. So my typical algorithm used to be, and still sometimes is, to go to an Astato 40 first. So in this case, tried to use an Astato 40. The blessing is both a curse. The calcium is both a blessing and a curse in this case. The curse is that it's very, very hard to cross, very tough occlusion, but on the plus side, we have a roadmap of where we need to go because the vasculature is so calcified, you can see the whole thing. So following in orthogonal views and kind of gently manipulating, trying to get across, the Estado 40, I could not get to go to the right spot in the popliteal. So what do you do next? One option is to kind of loop subintimal, and if that goes, we get lucky, great. If not, then the case is sort of over. So in a year or two ago, there was no further escalation to be done, but now we have a 60-gram penetration wire from Asahi that's been a total game changer. So this is a tapered, uncoated wire with 60 grams of penetration force at the distal tip, 014 and 018 options designed for this sort of occlusion. And the effective penetration force is about 3 times that of an Estado 40. So with the 60-gram wire, I was able to cross with an acute bend across this osteal AT into the pop, checking in multiple views. Here's an example of being able to see this on ultrasound. In this particular case, the wire was actually across the occlusion and then through because it was going in a straight line, but was able to pull back and then redirect and get the case done. So back to this particular case, through the osteal AT occlusion into the pop, get a little bit further, and then more occlusion. So get a crosswalk angled up there to get a picture, and we have more of the same. And then back to the 60-gram wire, and again with a nice calcium roadmap of where we need to go, able to kind of manipulate and get through. This 60-gram wire, as I said, is uncoated and tapered down. It is really designed to engage the CTO cap and not divert subintimally to kind of go through that point of most resistance, which is what you need to do to cross these lesions luminally. So in this case, got the 60-gram wire through, was able to get through. This is an example of doing this on extravascular ultrasound guidance. Let's see, my video didn't play there. But in any case, often can be done on extravascular ultrasound guidance. The wire shows up beautifully on EVIS, and that can be a nice way to cross when you don't have a calcium roadmap like this to tell you exactly where you're going. So in this patient, looks like we're frozen. Well, in any case, in summary, we were able to get through in this case drug-coated balloon angioplasty with atherectomy, got a beautiful result, inline flow all the way down, and essentially made possible with this kind of new wire line. So this has really been a game changer and really redefines what's crossable and what's not crossable. Thank you so much.